All right, good afternoon. We started the session, and the session is about the treatment of Mycobacterium tuberculosis. Learning objectives, as usual, with some additional things, and that is the general principles for Mycobacterium tuberculosis treatment. We will talk a little bit about the characteristics and understand why the treatment is relatively more difficult when compared to the antimicrobials that we talked about before. We will differentiate treatment of active or chronic versus latent disease. And then after that, the second part is going to be focused on 4 drugs that are typically used in the treatment of Mycobacterium tuberculosis, and that is isoniazid, rifampin, pyrazinamide, and ethambutol. And very few slides to cover each one of them, mechanism of action and some peculiar toxicity. To start with the challenges of Mycobacterium tuberculosis treatment, they have a cell wall. Now, of course, the other bacteria have a cell wall. We already saw that they have the peptidoglycan cell wall. But in addition to that, you already know that tuberculosis have additional structures. For example, they have the mycolic acid, among others, that give them their acid fastness. So this is an additional challenge on top of the peptidoglycan cell wall that we already discussed. Another challenge, they can replicate both intracellularly and extracellularly. So when they replicate intracellularly, we have to get the drug go inside the cell. 3, they can be dormant. And if they are dormant, they're not actively replicating. And this is the reason why when we treat Mycobacterium tuberculosis, we give it for a long time, right? For example, if I want to treat a tonsillitis, it could be for 7 days. Otitis, it could be for 14 days. Tuberculosis, depending on whether it is latent or active, it's going to be for months. So why do we need to give so much prolonged duration of treatment? Because of the dormancy. And also we have primary and secondary resistance. Of course, primary and secondary resistance are inherent properties of other bacteria, but here it is a little bit more problematic, as we will see in the next slide. To discuss primary resistance, we have significant genetic diversity among the bacteria and the Mycobacterium tuberculosis. And as a matter of fact, in a lesion, 1 in a million organism is going to be inherently resistant. So why? The so why comes in this slide. You already took the session with Dr. Kanj, I believe, about tuberculosis, and you differentiated latent versus active or chronic. The difference is in the load of the organisms, how many organisms we have. In latent TB, the number is written here, 10 to the power 4 or 10 to the power 5, which is less than a million, right? So most probably, we don't have an inherently resistant bacterium, and hence 1 drug could be enough. So for treatment of latent TB, of course, we want to give a prolonged duration of treatment because we have dormant cells. However, 1 drug could be enough. In contrast, when we deal with active tuberculosis, we need to give many drugs because we have a larger load and we already have inherently resistant bacteria. Is this clear, Jamia? So far we discussed 2 principles. 1, why do we give a long duration? 2, why do we give more than 1 drug in active TB? More principles. Next. Now is the talk about acquired resistance. And we already know the mechanisms of acquired resistance, but why does it happen more so with Mycobacterium tuberculosis? Simply because we have to give the drug for a prolonged duration. And the issue when you have to give it for a long time is non-compliance. You don't take the drug anymore. It is feasible to take a drug for 7 days, 14 days. When it becomes a month of therapy, it's hard. And we always forget drugs. If I have hypertension and I'm taking a drug every day forever, I may forget 1 drug here or there, and it's okay. It's not okay. If I make it, if my blood pressure doesn't go too high, it's okay. But with antimicrobials, this is a problem. I would have a time that is free of antimicrobial, and then that would lead to resistance. So non-compliance is a big issue. Other people at high risk of resistance are when you have poor socioeconomic status, crowded area. I'm sure that you took that with Dr. Kanj already. So this is a problem. Secondary resistance is a problem. And so we have multi-drug resistance. Because of that, we have multiple drug regimens. There's no one regimen that we use and that's it. We have several options, and it really depends on where we are, which country we are, what kind of resistant patterns we have. The first line therapies are the 4 drugs that I'm going to focus on in the second part, and that is isoniazid, rifampin, pyrazinamide, and ethambutol. Between parentheses, there's rifabutin and rifapentin. Those are like rifampin, but they are longer acting. And it's kind of nice to have longer acting drugs, as you will see why in a couple of slides. Second line therapies, there are several. We have, for example, here you see fluoroquinolones, you see aminoglycosides. We already talked about drugs that we could use for tuberculosis. But they are second line. We'd rather start with the more specific therapies for tuberculosis rather than take, for example, a broad antimicrobial that could target something else for tuberculosis. So how do we treat? For latent disease, we agreed that for latent disease, 1 drug could be enough. And there are several protocols, of course, not for your memory, and those things change, and it depends on where we are. But the point is that 1 drug could be enough. For example, we could give isoniazid for 9 months. We could give rifampin for 4 months, although some people don't like this regimen because, again, rifampin, you will see in a couple of slides, is actually an antimicrobial that you can use for other infections, such as gram-negative bacteria. Or you can combine rifampin and isoniazid and shorten the duration for 3 months. Now, if we have MDR-TB, multi-drug resistant TB, what does it mean? It means that we have resistance to rifampin and isoniazid, the first line drugs. In this case, we cannot give those, and we have options. Not for your memory, those things change, and it really depends. So you could give pyrazinamide, ethambutol, fluoroquinol, whatever, and then you can have extensively drug-resistant TB. Also, you have additional options. But the first line, if we are dealing with a non-resistant bacterium, then rifampin or isoniazid would be okay. Yes. Because 1, we don't have it in Lebanon at least, and 2, we discussed that it is very, very, very toxic. Not very, very toxic. It is associated with very serious toxicity. Treatment of active disease. So we were done with the latent, now active. Active disease, we agreed that 1 drug would not be enough because the load is already high. We differentiate active therapy into 2 phases, the initiation therapy and then the continuation therapy. Initially, for 2 months, again, this can change, but those are the basic principles, we give 4 drugs, 4 together, isoniazid, rifampin, pyrazinamide, and ethambutol. We start with 4. And then, of course, before you start treatment, you have to take cultures. And once the cultures are out or the PCR test is out and you know the resistance patterns, if it turns out that the bacterium is sensitive to isoniazid, rifampin, and pyrazinamide, you can remove ethambutol from the cocktail. Okay, so you start with 4, but you may end up with 3 based on the susceptibility of the bacterium. After the 2 months, we have the continuation phase, and that could be 4 or 7 months, depending on 2 things. 1, cavitary disease at presentation. What I mean here is a chest X-ray, whether we have a cavity in the lungs, and the culture results that comes up at 2 months. What do I mean by this? This is an example here, again, not for us to remember, just for us to understand the principle. So we start with the 2 months, and then to decide on the continuation phase, whether it's going to be 4 months or 7 months. For example, if I read the very first row, we have no cavity, and the culture is negative, then I can continue therapy for 4 months, versus the last row, if I start with a cavity, I have a positive culture, then I have to continue treatment for 7 months. And again, those things change. We just talked about treatment of latent TB. We talked about treatment of active or chronic TB. We defined initiation and continuation. Now I want to define the term intermittent therapy. Intermittent therapy could be done for active disease. And what does it mean? It means that instead of giving the treatment every day, you give it as 2 or 3 doses per week. And this is good. Why? For compliance. It's hard to take a drug every day. Maybe it's easier to tell myself I'm going to take the drug every Monday, Wednesday, Friday, or whatever. For compliance issue, it's easier. We can do that for all basic 4 drugs: isoniazid, pyrazinamide, rifampin, and ethambutol. This can be done only for the continuation phase. So the first 2 months, the initiation phase of active TB, we do not want to give intermittent therapy. This is acceptable only for the continuation phase. This is 1. And 2, it has to be done under DOT, and that is directly observed therapy. What does it mean? If I am a patient who has tuberculosis, you don't send me home and you tell me take those drugs on Monday, Wednesday, and Friday. I have to come to the center, and the nurse has to see me actually taking the drug. This is very important. So it has to be done under DOT. We are spacing the frequency of the drug. We don't want to miss a dose.
Doesn't it make it worse for compliance?
Well, it depends. I'm not asking you to go from north to south to do that. This is basically something that could happen in Africa, for example, where you would have a center that treats tuberculosis and people would have to come and take the drug. You don't want to let them take it by themselves. I'm sure the literature has shown that this is something good, otherwise it wouldn't be done, I would assume.
Are all 4 drugs used PO?
Yes. Some drugs can be given IV and all drugs can be given PO. Actually, we're going to see that in the next table. And of course, that technique, that intermittent therapy, should never be used for resistant TB, right? So to answer your question, please, not for your memory, just to make a point. So on the extreme left, we see the drugs that we've been talking about. We have isoniazid, rifampin, and then rifabutin and rifapentin being long-acting, pyrazinamide and ethambutol. And as you can see, for example, isoniazid can be given IV, IM, PO, but all of them can be given PO. And you have the daily dosing and the intermittent dosing. All of them can be given intermittently. What you would see on the right is that this is, again, general principles. If we're dealing with pediatrics age group, then it's different. If we are dealing with other groups, such as patients with HIV AIDS, then it's completely different story, etc. But this is the basic principle. All right, to understand this intermittent continuation and all of that stuff. Okay, next. And now you realize that at points we're going to be taking 3 drugs at the same time, which is not fun. So drug companies have actually combined drugs into 1 pill. For instance, we have isoniazid, pyrazinamide, rifampin in 1 pill. And we also have isoniazid and rifampin in 1 pill, and we have others as well. The point here is to try to improve compliance as much as possible. We're done with the first part. Let's have 2 quick clicker questions and then shift to the next. I mentioned the answer. You should know it. It's a fact. All right. I'll hit enter. It's one of them. What I have said, that we start with the First, we start with the 4 drugs together, and then based on the susceptibility, we can remove ethambutol. Okay, so the answer is E. It's a fact. Another clicker question coming up. I'm reminding you here of the structures of the outer part of the bacteria, or the gram-positive, gram-negative. We have a peptidoglycan wall. And for the Mycobacterium tuberculosis, we also have a peptidoglycan wall, but we also have additional structures, as we agreed, such as mycolic acid, which is important because this is where the mechanism of action of isoniazid is. And this is the mechanism of action of isoniazid. By the way, it is bactericidal. There are several proposed mechanisms, but the one that we will memorize is that it inhibits the synthesis of mycolic acid. How does it do that? Very simply, it inhibits the enzyme INHA, the bacterial enzyme INHA that is involved in the mycolic acid synthesis. The title of this slide is bacterial resistance to isoniazid. This is in contrast to the one that will come after it, which is the host resistance. So how is the bacterial resistance to isoniazid? There are two mechanisms. Either we have a mutation in the target enzyme, and that is INHA, that is inhibited by the isoniazid. But I failed to mention that isoniazid is actually a prodrug that is activated to its active metabolite, and this happens by a bacterial enzyme called catalase peroxidase. And as a matter of fact, the most common mechanism of resistance is by a mutation to the catalase peroxidase. We got that? Yeah.
So the catalase peroxidase is in the mycobacteria?
Yes, this is a bacterial enzyme. Yeah. So this is the bacterial resistance. We as a host could also be resistant to the drug. If you remember with me when we talked about genetic polymorphisms, well, the oldest pharmacogenetic example is with the N-acetyltransferase enzyme, the NAT enzymes, and we could be a fast acetylator or a slow acetylator. If we are a fast acetylator, we get rid of isoniazid more quickly, and we could be more resistant to isoniazid. So two things with isoniazid to mention. Toxicity, hepatitis, hepatotoxicity is quite common. It happens with older patients much more than younger. Slow acetylators, you would expect why. And this is especially in combination with rifampin. Do we usually combine isoniazid with rifampin? Yeah. So you will see that three of the four drugs that I'm going to be discussing right now are associated with hepatotoxicity. And when you give them together, the risk is even higher. This is why when we give those drugs, we want to follow up maybe with the liver enzymes, ask for symptoms, etc. Now, at least this is reversible and probably never fatal. Yes?
This is why when a person is taking drugs for significant.
This is one of the reasons, definitely. Yes. Like last time we talked about alcohol, we have several reasons, and this is one of them. Another one we're going to see in a minute is associated with GI toxicity. All right.
Do we just give isoniazid for TB, or do we give it in general to mycolic acid synthesis?
We give it when we have, so when we have tuberculosis, we could give isoniazid among others, and this is associated with hepatotoxicity, so you don't take alcohol. But what's the question?
Isoniazid. It's used for against mycolic acid synthesis. So do we give it in other cases, or is it too extreme?
No, you wouldn't. No. All right. Additional toxicities, neurotoxicity, peripheral neuropathy. This is why we tend to give vitamin B6. I'm sure you know somebody or one of you have done what we call it, the PPD test, and it turns out to be reactive. And we did a chest X-ray and it's negative. So we would say that this person has latent TB. And in this case, we agreed among each other that you could give isoniazid for 9 months, right? And when we do that, most probably that person took vitamin B6 at the same time to prevent peripheral neuropathy. And maybe there was a follow-up of liver function test at the same time, okay? Hypersensitivity could happen, and drug-induced lupus. You took lupus already, right? Okay. Next, we're done with isoniazid. The next one is rifampin. So this is the structure of rifampin. It is an antibiotic because it's derived from streptomyces. And I mentioned earlier that rifampin is not only for Mycobacterial tuberculosis, it's actually a broad spectrum antimicrobial. It can cover gram-positive and some gram-negative bacteria. And here I mentioned Neisseria and Haemophilus influenza. Neisseria meningitis, we talked about it for meningitis, and if I want to give prophylaxis for people who are exposed, we mentioned at the time that you could give a fluoroquinolone, if you remember. Another option, you can give rifampin as well as a prophylaxis for exposed people. It can also be combined with vancomycin for MRSA. Mechanism of action, it's bactericidal, we're going to remember that. Mechanism is inhibition of transcription, so it's not specific for mycolic acid, right? It's something that can work on other bacteria. Inhibition of bacteria DNA-dependent RNA polymerases, and we expect some selective toxicity because our polymerase is different from the bacterial polymerase. However, we can still have toxicity, especially for mitochondrial RNA polymerases. And we can have resistance, such as RNA polymerase gene mutation. Toxicity, what do you expect to see on the next slide? Something that I already mentioned. Hepatotoxicity, yeah. So next slide, the one after, sorry. The slide that came before this one was about bacterial resistance. Here also, we have some host resistance. If you remember again, with the pharmacogenetic session we had long time ago, rifampin was listed among the inducers. It induces every single CYP enzyme you want. And itself, it is metabolized by CYP enzymes. So it induces its own metabolism. And once you have the deacylated rifampin, it goes into the bile. So now is the toxicity. Point number 2 is hepatitis, hepatotoxicity. And this may be more common in children, and we may see that in combination with the other drugs. Orange discoloration is problematic. Now, this is not serious. It's no big deal, but the color is a big deal. The urine would be orange, the sweat would be orange, the tears would be orange, and the contact lenses would be orange. And this is kind of scary. So we have to tell our patients about that. If we don't tell them, they're going to freak out. And what would they do? Stop the drug. What will happen? Resistance. So we, as physicians, we really have to do what we call the prescribing process, talk to our patients. We don't tell them every single side effect that can happen because they will not take the drug. It's a balance on what to say and what not to say and whatever. Okay. Other side effects that we could see are hypersensitivity reaction, light chain proteinuria, and this may lead to kidney problems, and CYP interactions, right? If you remember the TBL case we had a long time ago, it was a patient who had HIV and then took rifampin, and there was this issue of drug-drug interaction. This is real, this can happen. So those are three, this is one urine cup on the right, this is normal urine. On the left and in the middle, I don't remember anymore which is which, but I'm going to tell you that one of them is blood in urine, and one of them is orange discoloration because of the drug. And they look quite the same. It's kind of scary. So you really have to tell your patient, don't worry, your urine is going to look like blood. It's all right, this is because of the drug. Lenses, maybe you don't want to use lenses. I don't know. Third drug, pyrazinamide. This is a synthetic pyrazine analog of nicotinamide. It looks like nicotinamide. Remember, I told you before that we have several anti-tuberculosis drugs that look the same, like isoniazid and pyrazinamide. Mechanism of action, similar to isoniazid, it's also bactericidal. I think we only have one side on side effects. GI disturbance, back to haunt us. Hepatotoxicity, so now we have 3 drugs that are hepatotoxic. Could we be giving them together? Definitely. Rash, arthralgias, and hyperuricemia. Those are the most common or the most serious side effects that we want to remember. Good. Shall I continue? Yes. I have no idea. Why are you asking this question? Have you read it somewhere? I have no idea. Could you find the answer and send me an email and teach me? Promise? Because somebody forgets every time this happens. So the question is, can we use it to treat rickettsia? My immediate reaction is no, because the mechanism of action is on mycolic acid, but I have no idea. There could be additional stuff. I don't know. Teach me, okay? Next, almost done. Ethambutol is the last drug. Mechanism of action is unknown, but it could inhibit RNA synthesis and mycolic acid metabolism. The problem with it, so here we don't have hepatotoxicity, but the problem is inducing peripheral neuropathy, especially retrobulbar optic neuritis with color blindness. So this is contraindicated in children who are less than 5 years of age. This can happen to adults. It doesn't only happen to children, but the problem with children is that we cannot check for color blindness easily. For adults, you can check it. There are tests, but for children, it's really hard. Trust me, when you go to the ophthalmology, and you will see how difficult it is to get the children read and tell us if they see or they don't see. So it is contraindicated in children less than 5, and this is the only drug that is bacteriostatic. So far, all the others are bactericidal. We're done, actually. We have 2 clicker questions, and we're done for today. And you should know all the answers. I've said it 1 million times, right? No, مش معقول يعني. It's not isoniazid, okay? It's rifampin. Next,